Great. Thank you, everybody, for being here. My name is Stuart Schlossman. I'm president and founder of MS Views and News. Today's program is sponsored by Bristol-Myers Squibb, and internationally, we want to give them a virtual round of applause, all right? I want to thank everybody for being here and thanking them for, helping us to do today's program. This is about wellness, all right? This is the MS Wellness Summit. We do this periodically. Today's program, again, it's an MS Views and News program. Now we're going to ask Dr. Baity to please join us because I want to read her bio and I want to get her up on the screen. Dr. Baity, where are you? Come on down. The price is right. There you go.
Hey
Perfect.
there.
Thank you. Thank you very, very much. All right, everybody, this is Dr. Jessica Baity. She is board-certified neurologist practicing in South Louisiana. She graduated from the LSU New Orleans School of Medicine, where she also did her internship in internal medicine and her residency on neurology. Prior to practicing medicine, she worked in the fields of foreign language and international relations and owned a foreign language instruction and translation company. Wow, that is a tongue twister in itself. She received her undergraduate degree in international studies and history from the University of Miami and her master's in internal relations from American University in Washington, D.C., a native of New Orleans. I'm not going to keep going and going. Let's let Dr. Baity get started with her subject. She also will be speaking for 30 minutes. We will then do a Q&A for everybody. Please remember, please keep your questions relevant only to what Dr. Baity is speaking about. And let's take it away. Thank you.
Thank you so much, Stuart. What a great presentation from Dr. Mehta. That was so interesting. I'm really going to start incorporating some of those things into my practice. So it's really great to be here and speaking with y'all this morning about MS. So I'm going to talk a little bit about MS basics, and we'll just dive right into the presentation. So just a little disclaimer, I'm not representing any sort of drug company. This is all educational and nothing else to disclose. So who am I? Stuart already gave a little introduction, but again, I'm a board-certified neurologist. I practice about an hour south of New Orleans in South Louisiana. I graduated from the LSU School of Medicine in New Orleans after going to University of Miami and American University in completely unrelated fields, and then went back to school to study medicine. Like I said, I'm a native New Orleanian, mom, wife, musical theater lover, travel addict, essentially a normal human like everyone here. But most importantly, I'm an advocate for my patients, and that's why I do this, to give a little bit of education and to kind of reach out. So the goals of this presentation: to empower patients and their families with knowledge. I believe that knowledge is power, and a lot of people don't know the basics of MS, whether they're patients or whether they're family and friends. So this presentation, I hope that you'll walk away from it feeling empowered and knowing about MS. I want you to understand what MS is, how we diagnose it, how we treat it. I want you all to recognize some typical and atypical presentations and some risk factors for MS. And then briefly, we'll talk a little bit about living your best life with MS. Okay, so let's go. Let's talk about it. All right, so let's go through some patients. Patient number one, this is Sarah. She's 32. She's a mom to 2 little girls. She works as a 7th grade teacher, teaching middle school, God bless her. And about a year ago, she woke up and she stood up and noticed that her right leg just gave out from under her. Her husband had to carry her around for about a week. She just couldn't get around the house. And then just sort of magically, the symptoms resolved and she felt better. She thought maybe this was her sciatica because she does have a problem with that sometimes. So she never saw a doctor, never was diagnosed with anything. Over the next few months, she noticed that she was very fatigued, extremely tired, had difficulty keeping up with her lesson plans, keeping up with teaching, and her family told her, listen, you got to start exercising more, you have to start taking some vitamins and taking care of yourself. Next slide. Patient number 2, this is Carl. He is 47. He's a truck driver, which he's been doing for over 20 years, and he loves to do it. Over the last few years, he started to develop some pain in his back, and he noticed this shooting sensation down his back and down his leg. He ignored it because he had some back issues in the past, and he didn't think much of it. And then he started to notice that his leg was sort of jumping and making these jerking motions that was very odd to him. He couldn't control it, so he went to the emergency room at one point, and he was diagnosed with a seizure disorder. They started him on seizure medications. And then a few months later, he had an episode of urinary incontinence, which was new for him. And his son said, "You have to go see the doctor about this." Next slide. And lastly, we have June. She's 65. She's an active grandmother. She has 5 grandchildren. She takes care of them after school. Over the past year or so, her daughter especially noticed that she was having some issues with her memory. She was becoming more forgetful. She would forget events that they had scheduled, misplace things. Her daughter started really wondering if she was developing Alzheimer's and dementia. And she didn't have significant past medical history, just a history of glaucoma, and had an incident where she had some pain and some vision changes in her eye. So her daughter insisted that she go get an MRI to work up what she thought was dementia, and it was read as potential MS or other demyelinating disease. So what do these patients have in common? They all have MS. That's why we're here, okay? So how can they all have MS when their symptoms are so different? So we're going to take a little look at MS so we can understand why they can all present so differently. So a little bit about the history of MS. It was first recognized in the late 1800s, in 1868, by a French neurologist named Jean-Martin Charcot, and he is extremely famous in neurology circles. He has about 5 diseases named after him. It was noticed prior to that, but he was the first one to give it a name. He called it sclerose en plaques because there were plaques or markings on the brain that he noticed. And through the years since that time, a lot of research has gone into defining MS, defining its characteristics. But it really wasn't even until the 1950s that we used any sort of treatment, and we used steroids. And then it wasn't even until the 90s that we developed any sort of preventative treatment for MS. But today there are many, many drugs, and we'll talk about that a little bit later in the presentation. So what is MS? This is the important thing to know. MS is a disease of the central nervous system, and the central nervous system means the brain and the spinal cord, as opposed to the peripheral nervous system, which is all of the nerves that come out of the spinal cord, the smaller nerves that go to your extremities. It is a demyelinating disease, which means that it destroys the myelin that surrounds the axons of nerves. So what myelin is sort of a fatty insulating material that surrounds the axon, which is the portion of the nerve that transmits information. And the myelin makes that impulse go faster and get to its target. So if the myelin is disrupted, that impulse doesn't go, the target doesn't get its information, and things just don't work correctly. So MS is also an autoimmune disease, meaning that autoimmune disease, meaning that the body creates autoantibodies to attack its own cells. So rather than attacking foreign cells, it attacks the body itself. Slide. But this is not the true story. This is a simplification. And, I think when I was first starting med school, we all learned MS is a demyelinating disease, but it is so much more complex than that. And the research in MS has been growing exponentially. It's honestly one of the hot topics in neurology. It's very popular these days. And there's been so much research lately to indicate that it's not just demyelination. There is inflammation, there are attacks on the actual nerves themselves. If you take a look at this very complicated picture here that would probably take an hour just to decipher, I just wanted to kind of indicate how complicated what actually happens in MS is. You have all of these inflammatory cells kind of surrounding the nerve. And what happens after an MS attack, when the myelin is disrupted, when the nerves themselves may be attacked by inflammatory cells. You have regeneration of that myelin, and it repairs itself to some extent. So when that happens, symptoms can resolve, they can get better. But the problem is that the myelin doesn't always resolve and doesn't repair itself the way it was before. So it's not what it was, which means the symptoms may completely resolve, they may not resolve at all, or they may partially resolve. And then when you couple that with the nerve itself being damaged, there can be a wide presentation of what happens after an attack. And that's what can make MS very confusing to people who don't understand the physiology, the pathophysiology, because it's not always the same repair process depending on the attack. And, symptoms can vary, really just depending on where that attack happened. If you look at this little diagram on the left of the brain is like a map, and it is very reproducible. Certain parts of the brain do certain things. The anterior portion of the brain is more motor, the posterior is more sensory, and so on and so forth. So depending on where that attack happens, that's where the type of symptom you're going to have. And then in the spinal cord, which you can see on the left, depending on the level of attack, you're going to have different symptoms. For example, if the problem is at T2, that's the area sort of around the belly button. So someone may have sensory changes there. It just kind of depends on where that attack happens. So this goes to explain why MS is so hard to diagnose. Even as a neurologist, MS can be quite difficult to figure out because there's no one symptom for MS. Everyone's symptoms are different. So looking at our patients we talked about, Sarah had weakness, she had fatigue, Carl had some nerve pain shooting down the back and an unsteady gait, and then June had cognitive dysfunction and visual issues. And these are really representative of patients that I have treated through the years, so this is real life. So how do we diagnose MS? I said it's difficult to diagnose, and it can be. We use a very strict criteria called the Mcdonald Criteria that is useful for what we call typical MS symptoms, and we're going to talk about that in a second. But what the Mcdonald Criteria requires is that we have proof of dissemination of space and time. You may have Googled this or seen this, and what that really means is that for space, you need to have lesions that are not just present in one location, but in at least two different locations in space. Maybe a lesion in the front of the brain, maybe a lesion in the brainstem, but different locations. And then by time, we mean attacks that occur at different times. One episode of weakness 1 year, 2 years later, one episode of numbness. Need to be not all happening at the same time. This is only useful for, like I said, those typical symptoms, which we'll talk about. But we usually diagnose this and say that someone has dissemination of space and time by doing MRIs. We get MRIs of the brain and of the spinal cord with contrast. So if you look down on the left there, you can see some what we call hyperintensities or plaques or lesions in the white matter of the brain, those little white spots. And then to the right, it's a little bit harder to see, but you can see little white, kind of bright areas in the spinal cord, and those are the plaques in the spinal cord. Sometimes the MRI is not completely clear. It's, like I said, it's not always very obvious. So sometimes we order a lumbar puncture or a spinal tap, it's also called. And in that, we're looking for the autoantibodies that I talked about. And we call these oligoclonal bands. And that's on the left, you can see those bright purple spots. Those are the bands that are present in the CSF, the cerebrospinal fluid, which is the fluid that surrounds the brain and the spinal cord. So we look for the antibodies there to sort of confirm our diagnosis. So I talked about typical MS. What does this mean? So there are these classic MS symptoms that I'm sure everyone who's gone to medical school learned about in their first Neurology 101 class, and that's weakness in an extremity. That's optic neuritis, which is inflammation of the optic nerve, which usually presents as a very painful, sudden loss of vision, sometimes with a red eye and tearing. There are sensory changes in kind of odd places. And when I say odd places, for a neurologist, we're looking for atypical paresthesias. In someone who, for example, is a diabetic, they get numbness in their feet, numbness in their hand, and that's very typical for us. But for atypical locations, we're thinking like the trunk of the body, the shoulder, just very odd places. There's ataxia, which can present as an ataxic gait, which is an unsteady gait where someone may be incoordinated and falling, balance issues. And then bladder and bowel incontinence, as well as retention, not just incontinence, but just bowel and bladder dysfunction. So those are some of our typical symptoms. So who is the classic person that gets MS? Again, in Neurology 101, this is what you learn, that the classic MS patient is young, in their 20s and their 30s, female, Caucasian, and from northern climates. So that's like when we look at our patients, Sarah is sort of our classic MS patient. But what about Carl and what about June? So what you learn, later when you learn more about MS is that while most patients present young, there's actually a bimodal distribution of presentation, meaning that there's a peak of younger patients who present, and then there's a second peak for patients in their 50s and 60s. So there can certainly be presentation at that age. Men can also get MS. People of color can also get MS. And I think, often these patients get missed because we're looking for these classic MS patients, young Caucasian woman, when everyone can get it. And I mention this because I see everything. I practice in South Louisiana, which is very warm, very sunny and hot, and I see a lot of MS patients. So it's not just northern climates. So that's something to really consider, as you're going to your physician and you're having symptoms. It's important to see a neurologist who kind of knows about these kind of atypical presentations. So what are some MS risk factors? A lot of people ask me, my sister has MS. What's the likelihood I'm going to get MS? There is certainly a genetic factor, certainly a predisposition genetically. If you have a first-degree relative who has it, you have about a 2 to 5% chance of developing MS. This is opposed to 0.1 to 0.2% risk of the general population. So you can see it's actually fairly rare in the general population, but certainly a bigger risk. And then identical twins have an even greater risk, 20 to 30% chance of developing MS. There's some environmental factors also. One that is kind of gaining traction in research is Epstein-Barr virus, that's EBV, and that's the virus that causes mononucleosis, the kissing disease. And there's been a pretty significant link. Of course, not everyone who has EBV or mono gets MS, but it is certainly, there's a correlation there. Vitamin D deficiency. Again, we don't know if it's causation, but we certainly see a correlation. And tobacco smoking is another big one. I mean, as if tobacco wasn't bad enough for you in every single aspect of your health, it is also correlated to MS. Obesity is well correlated. And then northern climates, I mentioned that already. And not sure if that is related to the vitamin D deficiency. We're not clear what the relationship there is, but certainly it's present. Little fun fact, caffeine is associated with a decreased risk of MS, which thankfully for me, because I love my coffee, right? So I talked about typical MS. So what is atypical MS? It's really interesting because the most common MS complaints are these atypical symptoms. So what is that? Fatigue. This is the #1 complaint of people with MS that kind of prevents them, especially from living, the best life they can live, the fatigue. What else? Pain is another. And cognitive dysfunction is another. And what's interesting about these very common symptoms is that they are really invisible. So I think that's what makes it really tough for MS patients, that people can't see their disease. They can't see that fatigue or that pain that they're feeling or that confusion. So it can be really difficult to, I don't want to say get sympathy from people, but certainly get empathy and understanding, because people can't see them, because these are super common complaints. So how do we treat MS? You might recognize some of these pictures here. In a short word, we give drugs, we give medications. So, Dr. Mehta sort of mentioned this in his presentation. Don't let medication be an ugly word. We are living at a really great time in MS treatment because we have so many therapies, over 13, and I say 13 plus because honestly every year there's more that I have to learn about and learn all the details about, but there's a lot of therapies to help prevent the progression of MS, and we call these disease modifying therapies, DMTs. There are many, and they don't necessarily fix what is already happened, but they help prevent the course of the disease. And a lot of these really need to be managed by a neurologist or even an MS specialist, depending on the severity of the case, because they require some strict drug monitoring. A lot of them are immunosuppressants, and that requires monitoring for different infections, certain vaccines you need to take, just monitoring over time. So it's really important to, like Dr. Mehta said, start these early and talk to your doctor about them. And this is just kind of a list that I threw together of some of the DMTs. You can see that there's a lot of different options. There's oral medications, there's injectable medications that you can give yourself shots at home. There's infusions where you go to an infusion center, or even infusions at home. These are all of the generic names. You may not recognize them. You may recognize more of the trade names, but you can see that there's a lot of them here. So, lastly, I want to get into living with MS. Neurologists, we treat it. We see the patient every now and then in the clinic, but the patients are the one that are living with this chronic disease. So what can we do as physicians to help you live, the best life that you can live? So the first thing that I'll mention again, is take the DMT, the disease modifying therapy, that you and your doctor decide is best for this time in your life. So what I really want to kind of get at there is that it's not just the doctor saying, take this medicine. This is the medicine you need to take. It's really a discussion with the patient about, what are your goals of therapy? What do you want out of this regimen? What are the aspects of your life that really need to be considered? And that may change over time. For someone who is 30 years old and planning to have a baby in the next few years, that may require a certain therapy. But then maybe 5 years later, you need to switch to something else. So it's a constant conversation that you're having with your doctor about, am I on the right medication for this specific time in my life? And I wanted to kind of give an aside about that. I mentioned, MS in pregnancy because this is something that I think often gets overlooked, but it's so important because, again, this is a disease that affects young women and women who are in their childbearing years and looking to start families. So I have seen a lot of women in my practice who said that they were told to not get pregnant because they have MS, even recommendations that they undergo hysterectomies and other sterilizing procedures to not have a baby. So I just want to say, no, that's not true at all. With planning, most women can have healthy pregnancies, healthy babies, and a healthy postpartum period, including breastfeeding. It's just important that you work with your neurologist, work with your OBGYN, and have them work together so that planning is the best way to do this. And then if, surprises happen, they happen, then, letting your doctors know as soon as possible to get you either off of a medication or on the right medication. but certainly possible to have a healthy pregnancy. So what else? Step 2, find a support group. And you're kind of doing that right now. You're here listening to this presentation. You are one of 185 people who are on this call right now trying to get support for MS. And this day and age, we don't have to do support groups like we did years ago, like in this picture where you go and meet with people and you discuss things, because we have the internet, we have social media. There are so many ways to reach out and talk to other people who are dealing with this disease, and not just people with the disease, but family members and friends. It's important for all of y'all watching to talk to other family members and friends so that you can understand, what your loved one is going through, what they're dealing with. But not to say that virtual is the best, because it is always great to just know someone in person and talk to someone. So you can say, oh, yeah, I also have problems with my vision there, or I have numbness there, and you can compare. And it sort of makes you feel normal, because a lot of MS patients that I have say, I just always feel like I'm crazy, because people don't see the pain that I'm feeling or the fatigue that I have. But when you meet with other people who are also suffering from this disease, you realize, actually, this is pretty common. I am not crazy at all. So get a support group, whether it's in person or whether it's virtual. That's huge. And lastly, do your research. Follow the trends, and you're doing that now. You're here listening to some of the techniques that you can learn, not just about medications that may be coming down the pipeline, but techniques like acupuncture or yoga or things like that that can help you live a better life with MS. But in terms of therapy, you don't have to be a physician or a nurse or in healthcare at all to follow the research. If you become a member of the National MS Society, you can get access to a lot of information, reading different publications. Be very careful about where you get your information from, because there's a lot of false information on the internet. So you want to really follow reputable organizations, the American Academy of Neurology, the MS Society. Those are places you want to go to get, up-to-date information that's accurate, scientific. And then, you want to share that research and share that with the community that you have. Next slide. So I'll leave you with this little quote: never let the things you cannot do prevent you from doing the things you can. MS is a chronic disease, but it is possible to live a full, happy, healthy life with this if you can implement all of the techniques that we're talking about today. So thank you so much. There's me on one of the happiest days of my life when I got my vaccine. So if you want more information on MS, here's a few websites to visit. You can visit me on Instagram. I post a lot about MS and just neurology in general for some information. So I'll just leave it there for questions.
Awesome. Thank you, Dr. Baity. Again, for the international MS community, we all thank you for doing this. Okay, great. We do have people on. As I mentioned earlier, I'm not joking. We have people that are from Europe. We have a person from Asia. We have a person from the African continent. I haven't seen yet anybody from Australia, but you might be there. Okay, and South America, I have no idea about either, but the others did let me know that they were there. Okay, so I wanted to make mention of that. Also, again, I'm asking everybody, if you tuned in, right? Like it's a TV show. All right, if you came on to this program late, please try to keep your questions relevant only to the topics that are being spoken per speaker. All right, and you could use the scroll bar on the right side of the screen. At the very top, there's an orange box with an arrow in it. You can click on that box and type in your question, okay? And I will get to it hopefully as soon as I can. All right, so for Dr. Baity, we're going to be asking questions for about 20 minutes, give or take. And then we're going to have Trevor Wicken follow, and he is the fitness expert. Okay, so let's start off with some questions that we got first from people when they registered for the program. I'm newly diagnosed with MS. How do I know when I'm having a flare-up?
This is actually a really great question, because there's something called pseudo flares as well. So an actual MS flare is a new symptom. And when you're having that symptom, you want to make sure that you don't have anything like an infection going on, because infections can often sort of make it feel like your previous symptoms are flaring up. Infections can, heat can. So, if you've been out in the heat, for example, and then you start to develop some weakness that you used to have, that's probably a pseudo flare. But if all of a sudden you develop some new symptom that you've never experienced before, that's a big red flag, and you should definitely go to the emergency room as soon as you can, because as you probably know, you're going to get steroids for that flare.
Okay, thank you for that. Next question. How can I get my MS neurologist to be as concerned about me as he is about pushing the DMDs?
Oh, that's a good. I'm sorry that you feel that way about the neurologist that you have. I will say that I'm hoping that neurologist you see is really just concerned about getting you on the right medication that they think is going to help you. But I think, in general, when you see a doctor, what you want to do is kind of say, hey, can we slow down for a second and really talk about what I'm concerned about? Because, we're always running. We have a bunch of patients, and sometimes we also have to just take a breath and take a minute and look at the patient in the eye, and, they can tell us what exactly is concerning them. And then maybe they can take the time to explain to you why that DMT is really what they want you to be on.
Okay, thank you. So I want to let everybody know that I am going to try to get to your questions. I'm going to speak very quickly. Dr. Baity, please, we have more than 20 questions. You only have 20 minutes, so that's less than a minute a question, okay?
Okay. All right. I'll do my best.
Great, thank you. And by the way, somebody did respond that they are from Australia, and I'm not taking that time away while I say that, okay? All right, next, people of color. Somebody wants to know if people with color tend to get MS worse.
That's a great question. The answer, unfortunately, is yes. There is a evidence that people of color tend to present later and tend to present with more severe symptoms. And whether or not this is genetic, that's up for debate as well, because we all know that in most issues in medicine, people of color tend to present with worse presentations or worsening presentations, which some of that is socioeconomic and social factors, early treatment versus later treatment. Sometimes I think it may be involved with that delayed diagnosis. That's important too, and I talked a little bit about that in the presentation. So unfortunately, yes, but we don't really know why.
Okay, thank you. All right, next, what medicines are on the horizon to deal with spasms?
I haven't heard of too many new ones. Carbamazepine is kind of our classic one that we use, and baclofen to some extent, although that can it can cause some weakness as well. Honestly, a lot of stretching is the best thing that you can do. The yoga that we talked about, some of those integrative medicine techniques are really the best thing for spasm.
Okay. How much vitamin D is too much?
That's hard to say. You probably have to get levels to know if your levels are too high. Usually if you take the standard supplement on the side of the bottle, you're going to be fine.
Okay, thank you. Now, Joy and many others have asked a question. When is remyelination treatment? When will it be available?
I wish I knew the answer to that. I don't know. Hopefully soon.
Right. Thank you. All right. Regarding COVID, I've heard that the vaccine is only 30% effective for MS patients. Is this true?
Oh, I'm so glad someone asked this question. No, that's not true. MS patients should absolutely get the vaccine. The problem comes from some of the immunosuppressing drugs. And if you're able to get a vaccine prior to starting those drugs, that's the best thing you could do for yourself, so that your body builds up antibodies before you start that suppression. But if you can't, if you're already on something, then it's what it is. That doesn't mean you have no protection, but it does mean that you need to be safe and wear a mask and surround yourself with vaccinated people.
Okay, thank you. Susan's saying MRIs have been stable for 9 years. So why has my disability progressed? I've gone from walking on my own to using a walker.
I'm sorry about that. it's possible that you've moved into the progressive stage. And the problem with the progressive stage of MS is that it doesn't necessarily correlate that well on MRI. We don't see new plaques. It's just sort of the plaques sort of converge together, and we don't really see the same progression that we can track. And I hope that that's not the case, but without knowing, your specifics, I would worry that that's what's happening.
Okay, thank you. I'm going to leave the name out on this one. Have you heard that menopause can cause MS?
No, never heard that. And I hope that that's not the case, but never heard that in any research.
Okay, thank you. Kathy's saying, I've had MS for 34 years, so no DMTs for 7 years. Now in my 60s, I'm concerned that there is not as much focus as I'd like on MS and aging. Should I be concerned on those 7 years not being on a DMT, or what can you tell us?
Oh, that's a really good question.
And to go further, she's still on a relapse-remitting MS treatment.
Okay. I think each individual is going to be different, and you can't really look back to those 7 years and wonder, what could have been, what should have been, because we just didn't have those treatments then. Where you're here, where you are now, and all you can really do is, give yourself the best medicine now, and not assume that just because you're older and that you have MS, you're going to have worsening dementia or more issues. You just treat yourself like any other MS patient. You look for your new lesions, you take your medication, you change your medication if you need to, but don't assume it's going to be worse.
Okay, thank you. Is it possible to reverse the illness?
It's not. We're not there with the therapies. I really hope we come up with a cure, to improve that nerve function. It's really tough when nerves are damaged in the central nervous system to fix them. The myelin, I think that's a potential treatment in the future, the remyelination. The nerves itself, that would be a Nobel Prize winning treatment, I would think.
Okay, next one. Does taking a certain MS medication make you worse? When I got diagnosed, I was walking with a slight limp. Now I'm worse. The doctors say there's so many meds on the market now for MS. It's not like 20 years ago. And all they have tried on me, though, is Ocrevus.
Okay. I can't speak to why you'd be getting worse on a medication. It could be that they started you on that medication because your lesion burden was high. Sometimes we jump to the more serious, more hardcore medications when we see a lot of lesions on MRI. Or it could be someone has had really a lot of success with the Ocrevus and that's why they prescribed it. I wouldn't think that it would make your symptoms worse. So I can't really say, why that's happening.
Okay. Next one I'm going to answer for you. A person's asking, do I stop taking a DMT at 55? No, not until you're dead. And then you don't have to worry about it.
Thank you.
Okay, great. Next one. I'm interested in your views on treatments with embryonic stem cells post HSCT to halt the underlying autoimmunity. Can you answer that quickly?
Well, not really. I don't know too much about it to really speak on it, but it sounds promising. That's all I'll say.
Okay. Can you answer anything about using an HSCT treatment?
No, sorry. I don't know enough about it to really speak on it.
Okay. So for those that are asking those questions, we do have a doctor coming up on August 10th that you can join our program at that time. That'll be with Dr. Aaron Boster, and he is very in tune with that subject and can answer you at that time. Just pay attention to, when the announcements go out to register for that event, that you do join that event. Okay, thank you. All right, next. Can you discuss IBS issues associated with MS?
So certainly MS can have issues with both the GI tract and the GU tract. And what we usually do is make sure that the patient is seeing the appropriate specialist for that, whether it's the GI doctor, the urology doctor, because mostly the treatment is symptomatic treatment. We don't usually, there's not a DMT specifically for those symptoms, but if you're having IBS, you may end up on the same sort of treatment that someone who has sort of just classic IBS with no MS has.
Okay, thank you. Tahinder is asking, is lack of appetite associated with MS?
I have not found that or heard that, but every patient is different, and because MS can affect the GI tract, it makes sense to me that there are patients out there who just don't really want to eat.
Okay. All right. Next, have you heard anything about the Myelin repair trial? And if yes, is it almost complete? And what effect will this have for MS?
Well, I haven't heard too much about that trial to give you any details about, how promising it looks. I'm gonna have to do a little bit more research on that myself.
Okay, thank you. Next one. What is the latest on SPMS?
Secondary progressive MS.
Yes.
So we do know that in 10 to 20 years after relapsing and remitting, that secondary progressive tends to kind of rear its ugly head at that time. But the thing is, a lot of those numbers and that research was done prior to all of these new DMTs. So as we kind of do more research for people who have been on these medications from the beginning of their diagnosis, I do think we're going to find that that number, that length of time has definitely increased. I don't know of any trials specifically that are doing that, but it's really my suspicion that secondary progressive MS is going to still be present, but to be present less and to be present later.
Okay, thank you. Interesting question Jody has. Is it necessary to have contrast during an MRI?
Yes, it is, because I like this question. The contrast is important for assessing for active lesions, because what happens when I talked about that nerve damage and that myelin breakdown, when that myelin breaks down, the contrast sort of seeps in, and that's what we see on the MRI. That's the contrast. So without the contrast, we don't know if you have an actual active lesion.
Okay, thank you. Next, what do we have? Have there been any studies conducted on benign MS?
I'm not sure what they mean by benign MS, maybe radiographically isolated syndrome. There are patients who have lesions on MRI and have no symptoms, and we refer to that as radiographically isolated syndrome. And it sort of differs doctor to doctor, if they decide to treat that or not. And in my practice, most of the time we don't treat that. We just watch those lesions over time, because MS is really a disease of symptoms and then lesions that correlate to those symptoms.
So I think that the person might be saying with benign MS, I've heard that usually it's like one instance of something happening and then never again to be seen, or has not yet again be seen.
Gotcha. So we refer to as clinically isolated syndrome, and that's that one instance. And usually the way we look at that is we still get the MRIs, and if you have lesions on MRI and you've had that one instance, we still usually treat that, but it's still called clinically isolated syndrome. It's not called MS. But if there's no lesions on the MRI, then oftentimes we just say, okay, we'll just watch them and see what happens and don't start anything.
Okay, thank you. Carolyn is asking, can people with progressive MS continue to walk, or is it inevitable that they will wind up in a wheelchair?
I don't like to say inevitable about anything. I think there is certainly a more likelihood that walking becomes difficult. But that being said, every person is different, and that's why you have to do everything that you can do to avoid that from happening with exercise and stretching and all of the things that you can possibly do. But so I never like to say inevitable. Is it likely? Yes, it tends to be likely, but not for everyone.
Okay, thank you. Neely is asking, how does Mavenclad work? My neuro says after the second year, I may never again need treatment. If it's that good, why doesn't everybody take it?
So, every drug has some significant side effects, and it's a strong drug and it can work, but if you are not having enough of a lesion burden or symptoms, we probably wouldn't put you on it just because of the side effect risk. And that's true with a lot of different medications. There's a lot of great drugs, but they're just not all right for each individual person.
All right, next, Robin is writing, you mentioned that if you're on a DMT and had not had a relapse, you should stay on it till you die. I was told by my MS neurologist that it can stop my DMT. Do you agree?
Well, I don't know her specific situation, but there are sometimes cases where people have not had a relapse in a long, long time. They don't have a significant lesion burden, and we could potentially try them being off of a medication. There's always a risk when you come off of a medicine, of a DMT, that you could have another relapse. So some physicians are more conservative than others and just no matter what, want to keep you on, but others say, okay, well, we can give it a try. It's really that shared decision making, between the doctor and the patient.
Thank you for this. Do you have any treatments that are known for vertigo or ataxia?
We use, again, symptomatic treatment, the same treatment that anyone would use, even someone who doesn't have MS. Meclizine is a common drug we use for vertigo. We also do a lot of gait training or vestibular physical therapy to it kind of teaches you how to navigate yourself in space. And maybe Trevor will talk about this when he talks about the MS gym, but there's techniques that I like because you're not as dependent on more medications.
Thank you. Next question. How can I know if I have trigeminal neuralgia? Surely there's definitely pain, but is there another way to know for sure if that's the problem?
Good question, because trigeminal neuralgia is definitely linked to MS. That's one of the causes of that disorder. And it is a shooting type of nerve pain in the face that's limited to one side of the face, really one section of the face. It will always be in the same spot. It is triggered by different actions like eating, like drinking cold beverages, just cold air, talking. It has triggers. So if you have a trigger that's causing it, then that's more likely trigeminal neuralgia and not just your average nerve pain. And if it's always in the same location, that's kind of a signal.
Great, thank you for that. All right, next, Carolyn asks, there are a few options of drugs for people with progressive MS. What is your opinion of Mayzent and a study drug called, I don't know if I'm going to say it right, Simvastatin or Simvastatin or something like that?
Okay, Simvastatin?
Yeah, that could be it.
Okay, I don't know that I've heard about that one. But Mayzent is, there are really only two options for primary progressive MS, the Mayzent and Ocrevus. I tend to use more Ocrevus. Mayzent has a little bit more side effect profile that makes it a little bit scarier for me, but maybe I'm just more conservative than some other neurologists. I think if you are to the point that you're having a primary progressive MS and you're going to be on one of those medications, you certainly want to follow with an MS specialist because it's going to require a lot of monitoring, a lot of blood monitoring and surveillance if you're going to be on that medication.
Okay, thank you. How does stress play a role in those with MS?
Oh, what doesn't stress play a role in? Every single disorder, chronic disorder, everything, stress is going to negatively impact it. So, implementing stress relieving techniques is so important. Therapy, yoga, just relaxation time, not pushing yourself too hard, not being too hard on yourself. I can't overemphasize enough the role that stress can play in MS and everything.
Okay, thank you. Next one, let's see. Do you have an opinion on Tecfidera? Any side effects? Do you have any opinion on any of the medications with any side effects?
So I really don't want to speak to to kind of give credence to any medication over another because I think they're all good. Tecfidera is a great medicine that works. So are all the other medications. Like I said, it really just depends on the individual person.
Okay, this next question I'm not too sure about, but her name is Leslie. She's in the United Kingdom, and I'm going to say it. Maybe you could figure it out. I've only ever had non-contact MRI, as neurologists said. There may be long-term issues with gadolinium.
Okay, so you've never had contrast. Okay.
Contrast.
So there are some studies that say contrast over time, multiple exposure to contrast can cause some issues with kidneys. But in someone with MS, it is I think at least important to have an MRI with contrast if you think you're having an exacerbation or flare. You know, in the screening MRIs in between those episodes, it's fair if you want to limit your contrast, because we'll still be able to see if there's new lesions. We just won't be able to see if there are active lesions without the contrast. So, you know, over a long period of time, maybe every now and then doing one with contrast would be okay for you, without knowing your specific situation and if you have kidney dysfunction, because contrast can be a little bit tough on the kidney. So that's something to consider.
Okay, thank you. The next question, I'm going to group a bunch of questions together and just make it more simple, since I can knock out probably 6 at the same time. And that is, why are some medications B-cell depleters and others not? And what is the benefit of a B-cell depleter?
So what's interesting about MS drugs is that they all have a different mechanism. There's not one specific way that they work. And some of them, like rituximab or Ocrevus, are B-cell depleters. That's just how they work, because your B cells are what make your antibodies, and your antibodies are what is attacking your myelin. So that's just one way that that medication, or one way that an MS medicine can work. They work great, so do other medicines. But it's important, if you're on one of those, to monitor for your B cells to make sure that you're still, you know, mounting an immune response.
Okay, I only have time for 2 more questions, so I'm sorry, everybody, if I didn't get to your questions, but it is what it is, all right? And you can always listen to some of our programs coming up in the future with other neurologists. Be online for those, and the easy way to know about those programs is to subscribe to our YouTube channel, and you'll know about the programs, you know about what's being put on there next. All right, so one of the questions, and this is an important one because I know a lot of people with this, how do you explain the phantom itching and what can be done for it?
The phantom itching. I mean, this is a type of neuropathy, you know, and neuropathy is quite common in MS. It's these lesions that are in the sensory part of the brain, or they're in the spinal cord, and nerve pain and nerve sensation, whether it's paresthesias, itching, numbness, they're weird, right? When you try to explain it to people, you sound crazy, but it's real. So how can we treat it? You know, I don't think that itching, in that sort of itching, responds well to traditional things like Benadryl, for example. So we would probably treat it more with neuropathic pain medications like gabapentin or Lyrica, Cymbalta, and just see if that would improve the symptoms.
Okay, thank you. Here's the final question I'm combining from 4 different people. All right, one, how do you get your teams of clinicians to work better with each other, between the neurologists, the physical therapists, and so on, regarding that, as well as donating blood? Is that possible? They've always heard no, and using infusion therapy, and that's where I'll stay with this for right now.
Okay. As far as getting the team to work together, that is so important, and it's kind of tough. We're so fragmented medically, I think. One thing that helps is when your whole team is in the same hospital system, where they can share records and they can just pick up the phone or go down the hallway and talk to each other. I'm lucky where I work that the physical therapist is just downstairs, and they sometimes come up and talk about, you know, different patients. And then there's like pain medicine down the hall. I can talk to them. So that can help. And just finding doctors that are open to talking to other doctors about your case is important. In terms of donating blood, I don't know the latest on patients with MS donating blood. They're pretty conservative, and I would say probably not. And infusion therapy, what was the question? Doing infusion therapy?
I don't think I asked one on infusion therapy, but
okay.
It was that was before we were doing something else about infusion therapy. Okay. But basically, you know, if there's any DNA testing also that can be done for people with MS, and that's it. We're going to have to. I'll tell everybody about this afterwards. But go ahead.
No DNA test that I know of. Not yet.
Okay, thank you very much for that. So I want to let everybody again know that, you know, unfortunately we couldn't get to all the questions. I wish we had another 20 minutes to continue, although we would not have needed that, but we still don't have enough time to go through all the other questions. If you do have questions, most of your questions we've already done with many of our programs in the past. If you visit our YouTube channel, which is pretty simple to do, you go to youtube.com/MS Views and News, or you go to our website, and there's a link on the left side of the page to access our YouTube channel. Once you go there, there's a search box. Type in infusion therapy, or type in physical therapy, or type in COVID, all right, or type in stretching, okay? It'll open up to all the different presentations we've already done on these different topics. So again, a lot of the questions that do remain all have been answered at a program in the past. And again, I'm sorry for not being able to do this. Dr. Baity, I do want to thank you again for being here. Bye-bye.